Now we're going to start with the questions, and we're going to go through the entire respiratory slide set for the questions. That is, anyone here would like to start this off? If anyone did this and would like to read it and answer A.
Yeah, I will.
Okay, go ahead, Ian.
Okay, so BLS has requested ALS assistance for a 67-year-old male respiratory failure patient. You are the lead paramedic arriving to assist BLS. You see BLS bagging the patient with a BVM at 102% oxygen. After your primary assessment and BLS report that they had to remove the OPA due to patient gagging and vomiting, you determine the patient has a failure to protect and maintain his airway and has a failure to oxygenate, and you decide to intubate. You place the patient on your monitor and tell the BLS crew, bag this patient up until the SAT is 100% on my monitor. As you are placed on hold to speak with Online Medical to get orders for conscious sedation, you observe one EMT squeezing the BVM once every 3 seconds using one-handed EC clamp technique. As his partner tells him, hyperventilate faster, we are only at 94 on the SAT. Okay, so A, explain the corrective action you would take immediately as the lead. So I would immediately put them, change from two hands to 4 hands.
Okay.
I would probably try to put NPAs in. And they need to put an Untitled CO2 on the bag valve mask and try to get it at 40 to 42, somewhere in there.
Yeah. So excellent, right? So you want to put your probe Untitled CO2, right? And you want to, 35, 45, depending on the, what the patient has. You also want to instruct them to use two-handed techniques. There's another name for it is called the triple airway maneuver, right? When you do a two-hand technique. I actually have several videos on YouTube where I showed that. And Peter Safar, right? He basically is known as father of CPR, the guy who, was the anesthesiologist who came up with all these techniques. He, in his practice in Baltimore, where he was anesthesiologist, he basically showed that the triple airway maneuver was the superior technique to one-handed technique. And two-handed technique will facilitate better oxygen delivery, ventilation, pre-oxygenation to your patient. So excellent. Two-handed technique, put an adjunct. I would put two nasal airways. Another name for nasal airways is nasal trumpet. So two nasal trumpets, connect your Untitled CO2, two-handed technique, right? And you tell the BLS crew, right, squeeze one breath every 5 to 6 seconds. Or you could say, squeeze one breath to maintain your capnography at 40, right? And the reason why is that that's probably a better, because capnography, as I said, is real time. But the pulse ox, there may be some lag if the patient is sick. So pulse ox lag does occur, but Untitled CO2 is real time. Excellent, right? So the corrective action would have been that. If I personally was on this call and after showing them, they still have issues, I would basically, what I would do is I would give the phone to my partner to contact medical control, and I would be the one holding the two-handed seal. All right. Remember, the technique portion is not the squeezing of the bag. The technique portion is you holding that proper mask and jaw seal, right? You lift the mandible into the mask and you hold that. That's the skill portion. Squeezing the bag, I could ask even, family member, police officer, firefighter to squeeze the bag. Anyone can squeeze the bag. But you as the, paramedic, you need to provide proper, right, technique. So if they're not doing it, you need to do it yourself. Then you could show them how it's done. But I seldom see people performing this right. To do this right is very, very difficult. Most doctors, PAs, paramedics, EMTs do not do this correctly in terms of two-handed technique. We're going to practice that in the lab. This is very hard to perform. And this EC clamp technique, where it all came about, it's from AHA, essentially. They needed a way to get this ventilation across to lay rescuers, because who takes BLS CPR? Anyone, right? If I need that certification, anyone can take it. You don't have to be, per se a healthcare provider. You could be, you may not be resuscitating patients on a daily basis. I could work in a dermatology clinic, right, where I never run cardiac arrests. And you're going to tell me the class I take is the same as an EMT who may work up cardiac arrest several times in their shift? No, right? So the techniques for the optimal airway management will definitely differ, right? The one-handed EC clamp, this is for your lay rescuer, right? You are not lay rescuer. You are here as a provider trained in the emergency procedures, right? So you're going to perform the optimal technique, not the most taught technique to lay rescuer. So excellent. So all that is good. Who would like to do point B?
I will.
All right, go ahead. Read the question first, and then you could.
You gotta scroll down. I don't.
Are you able to see it? So portion B right here.
Oh, okay. After the call is completed and the patient is transported to the hospital, how would you explain to the EMTs using materials you learned in the A&P lecture your rationale of what immediate actions you wanted them to perform and why?
So why? So basically the question says, right?
Mm-hmm.
They were using one-handed EC clamp, and they were squeezing the bag very fast. I think I said every 3 seconds, right?
Mm-hmm.
Knowing what you know now, right? How would you explain? Let's say I am the EMT on the call. I was doing that. To me, I understand pulse ox. You told me you wanted 100%, and I know to get it to 100%, I gotta squeeze the bag as fast as I can to get it to 100%.
Well, I mean, I would be concerned about professionalism, so I'll pull them aside and not, do it in front of other people.
Good.
And then you speak to them in a manner that's not condescending, but let them know that you're trying to help them understand what you want done. And then I would, let them know this is the end title number that we need to reach. I need you to squeeze, this many times per minute or whatever. It's just a matter of explaining. It's not what you're explaining, it's how you're explaining it to him.
Yeah. So tell me, like in a plain English, the way you understand, why squeezing like the bag would be detrimental. Someone raising their hand, you could talk.
I'll give it a shot. I didn't want to interrupt. I don't want to interrupt the guy speaking. That's why.
Yeah. You wanted to add something to this?
Yeah. I guess I'd explain it's not necessarily squeezing it faster. That would help. It was more just getting the seal correct, which is basically what you were saying.
Mm-hmm. But what remember? So the seal is important. But what effect does squeezing the bag rapidly do to oxygen on the hemoglobin itself?
So I would just say something like it's not about how much air gets into the lungs. It's about how much air goes to the muscles and the tissues. And so you need to slow down the rate in order for the oxygen to move into the tissues. Excellent,
right? Excellent. Lita said that, right? And we were talking about, right? If you squeeze too fast, you will left shift the oxyhemoglobin dissociation curve. And what that's going to do is going to switch it into the relaxed state where the hemoglobin wants to hold onto the oxygen more tighter. So what you want to tell them is, if you squeeze the bag quickly or fast, right? What you're going to do is the hemoglobin is going to keep oxygen loaded. Basically, if you're driving in the car and there's 4 oxygen molecules as passengers, that car will keep all the passengers in the car as it gets to the tissues. The doors will not open, oxygen will not come out to be given to the tissues. The tissues will not be seeing that oxygen, even though your pulse ox will show 100%, right? So that's what you want to be, informing them. So 1 breath every 3 seconds will left shift if you do it long enough. So you want to go back to doing 1 breath every 5 to 6 as you were initially taught. And you're, right, as Lamont said, right, you want to be professional about it, right? The reason why is that oftentimes it's, I may not know this. It's just I have not learned this, and I don't know this. It's not that I'm trying to, cause harm or, have, some untoward effects to the patient. This is your oxyhemoglobin dissociation curve. The implication of it is basically, the twofold, as I said, right? the steep decline as you reach 90%. So they will rapidly desaturate. So that's what you want to avoid. You want to back them up and try your attempt, right? You could try, if you did not see the vocal cords, right? You could, again, ventilate them, right? Pre-oxygenate them back to 100% and try again. You could always try again, as opposed to, trying to rush it and, sending this person to cardiac arrest. And the other factor being, if you squeeze too aggressively, you'll basically left shift this curve. And that's what I don't want to happen, right? So what you want to remember, what causes right shift? Right shift is caused by a lot of hydrogen ions, acidosis, right? Metabolic active tissues, high temperature, fever, sepsis, and this will switch into the tense state, get rid of oxygen. Left shift is usually the opposite, right? Alkalosis, low hydrogen state, low 2,3 DPG, low temperature, right? And fetal hemoglobin. Why? Because it has low 2,3 DPG, right? It was going to left shift, make the hemoglobin into relaxed state where it wants to maintain. I would also add, CO poisoning here. Carbon monoxide poisoning is going to left shift and hold on to that oxygen, and the tissues are not going to see it. Right? Any questions about this one?
Yeah, I have a quick question.
Mhm.
So when you're intubating, just because you can doesn't mean you have to, right? As in, if they're setting at like 90 for like good 3-4 minutes, would you just rapidly transport then, or would you just keep backing until you get like 95 and then you intubate?
So John, I really like your question, right? So when we do the procedures, right, you not only you're gonna get the skill sheet, right, that shows you the steps. How are you gonna get the skill sheets? If you saw the videos I made for MedMath, I put links in the description for all the skills you need. There's all the skill sheets for intubation, IVs, all the skills you need for your stuff. But what that skill sheet does not have is indications and contraindications for the procedure. So it will not tell you when it's indicated and when it's contraindicated. So for you to intubate somebody, they have to meet indications. The indications being, for intubation specifically, failure to oxygenate, failure to ventilate, failure to maintain or protect the airway, and expected clinical course is they expect it to decline. So to give you some idea, right? If you come in and you see a guy who has either failure to oxygenate or ventilate, we always start with BLS procedures first. However, if I know their medical course is to decline, meaning their disease process they're not going to improve. Like, I'll give you an example. Let's say the guy had burns, and I know as the process goes by, they may have swelling and edema, and it may close shut. So their clinical course is to decline. So I will then intubate this person because they met my indications. So we only initiate procedures when there's clear-cut indications, and you're going to be writing that on your ACR, and there is no contraindications present. So just to repeat, indications for intubation will be failure to ventilate or oxygenate, failure to protect or maintain the airway, and expected clinical course, right? Another expected clinical course, to give you another example, you arrive at a small hospital and you're transporting a patient into a facility to a big hospital that's 50 miles away. And the patient is in severe respiratory distress, and you know they're going to decline during transport. They cannot maintain that effort, right? So you may intubate them in the facility before you depart, right? That's a safe thing to do. The other thing, patient cannot protect and maintain. That means that even if I have an OPA and BVM, all right, the patient can vomit and they aspirate, right? I do not want that to happen. The other important factor is how many of you are there. If it's 2 of you as paramedics and 1 of you has to drive and the other person has to be doing other stuff, right? Do you have enough hands to, be doing BVM only ventilations? Because if the patient met my criteria, I will intubate, right, to secure the airway. And I have other tasks I also need to be performing. Maybe, initiate IV access, give them medications, monitor other parameters, right? So in terms of your skills, and this will go for all your skills, and I'll be asking you this, and this stuff is not on your skill sheets. It may not be in your paramedic book. So, well, where are you going to get that? You're going to have to do some research, right? You're going to have to go and see what are the indications. And I will always ask you that when we do skills, what are your indications? What are your contraindications? Does that answer your question, John?
Yeah, thank you.
All right. So yeah, so it's a good question you brought up. So make sure when you guys are doing your procedures, you know that. And the reason why this is crucial is that once you are paramedics, you are like, let's say you did not bother to look the stuff up, right? You are 100% responsible for knowing indications and contraindications. So if your medical director reviews your call and they call you and they said, how come you initiated CPAP for this person? Your ACR, and you better have clear-cut indications as to why, and they had the need for CPAP and clear-cut indications of no contraindications present, right? And if you're following this, you should be, good for your practice as a paramedic. All right. Any other questions for these two?
And
Yeah.
So Mike had a question about the EMTs, asking if it would be proper to say that increasing or actually doing the hyperventilation would increase the intrathoracic pressure and I guess ultimately drop their BP because of real.
I did not hear you, but let me rephrase it. Let's see if I got it right. You're saying if hyperventilate.
Can you hear me now?
I hear you now.
Basically the question was, is overventilating wrong because it can increase the intrathoracic pressure, which can ultimately drop the blood pressure, which can become a big problem.
So it can, but I would say you can increase the intrathoracic pressure and drop the blood pressure, but in some cases, that may not be my biggest worry. Like you may have a patient who has, let's say, a Cushing's triad, right? They had head injury and their blood pressure is elevated to their disease process. You squeezing the bag faster, right, is not going to per se drop their blood pressure. Yeah, you may entrain air and increase pressure there, but the problem there being is you left shifting them, and their status is they need all the oxygen they could get, especially for brain injury, right? And I don't want to make the hemoglobin into the relaxed form, and I don't want to blow off their CO2 excessively. So it's not per se so much of the worry of the rapid ventilation. When you're worried about it's perhaps if you're emptying the bag. So if I'm squeezing the bag and I'm using two hands, the BVM bag has about 1.5 liters of air, and I'm fully emptying it. Then you have potential of elevating intrathoracic pressure. But if you give your 500 tidal volume rapidly, it depends on the patient. If their blood pressure is okay or elevated, there's not significant decrease to the blood pressure that you're going to do. If their blood pressure is very low, yeah, you could drop their blood pressure a little bit further. But that's not my main concern. My main concern is, again, what happens to the oxyhemoglobin state, right? Those patients with head injury, I don't want to starve them of oxygen. Does that make sense?
Yes.
Yeah. Okay. Any other questions pertaining to this?
Yeah, to that effect of dropping the blood pressure, you were also saying that when there is a foreign body in the airway, when we push it down into the right mainstem bronchi, wouldn't, if we hit the carina or any of the inside of the trachea, wouldn't that cause the blood pressure to drop as well?
It may, and that because of the vagal stimulation you cause, it may, right? It may. But the problem is that if I don't have the airway, I'm not really worried about the blood pressure. It's let's put the priorities back in order, right? Airway comes before the blood pressure, because if I cannot get the airway, there will be no blood pressure, right? So can that cause drop in blood pressure? It can. If you vagal stimulate them, yes, it can. But if I have no airway, I have no blood pressure. So airway takes precedence, right? So that's why when we do patient assessment, it's always A, B, C first, right? If you don't have a patent airway, there's nothing you can do about the blood pressure in that regard. So, think of it like this: every procedure has some untold effects or inherent risks that it carries, but the benefits outweigh the risk. That's why we perform it.
Thank you.
All right. Any other questions about this? If not, we're gonna then proceed to the questions that I had, the multiple choice questions. I tried to select questions for you guys that will be pertinent in terms of your exams, but also helps you understand the material. So hopefully you guys took a look at them and did some of them, right? So we're gonna start with the multiple choice number 2. The reason why they're numbered like this is because I pulled them from another test bank. This is not from this book per se, so that we don't get any repeats. But the reason for the numbering is that so that I can see on my end, right, the key to make sure you do get the correct answer. So and anyone can participate if you guys like to. Just take a question number 2, read it, tell us your answer. Even if you get it wrong, that's okay. You still get credit for participation. You're not going to get marked or deducted any points if your answer isn't correct.
I'll do number 2.
All right. You can raise your hands and I will pick, I guess, whoever. All right. Jackson, go ahead.
Number 2, air entering the body is filtered, warmed, and humidified by A, the upper respiratory tract.
That is correct, right? So as the air comes in, right, we need to filter, warm, and humidify. Why? Because you're not going to entrain cold air, and your upper airway, right, the nasal passages, right, do all that. Excellent. So A is correct. 5.
I could do it. Crystal.
No, this. I see like 10 people raised. All right, let's do Alston.
The trachea, bronchioles, bronchioles, and alveoli all make up the number 5, right? B.
B is correct. Yep. Lower respiratory tract is correct. So at this point, right, you basically subdivide to the point where you have the gas exchange alveoli, right? CO2 and O2 exchange, right? So good, excellent. Next one, let's do Brendan Solis.
Alrighty, hold on, let me just move my little box here because I can't see it. There we go. Okay. The beating of the cilia of the respiratory passages in the direction of the pharynx forms the respiratory mucosa.
So cilia, right? Remember, what were the cilia? Cilia were these projections, right? That they move the mucus, essentially propel it up, right? So remember, there was a term that I used, right? So if they move the mucus, right? The mucus is moved by.
Oh wait, I'm sorry. It's the lamina propria. I'm sorry.
11. The correct answer is D. The reason being, it's the mucus escalator. Why is it the mucus escalator? Is that the cilia is what propels, right, all the goblet cells, right, all the secretions that are being made, and all the particulate matter up, right, through the cilia using that mucus ciliary escalator. So that's the answer for that. All right, the next one will be 16.
I can do it if you want.
Okay, go ahead, Angel.
The common passageway shared by the respiratory and digestive system is the D, pharynx.
Pharynx is correct. D is correct, right? The passageway with the respiratory and the digestive. Basically here, what they're saying, this is the esophagus, right? And the respiratory here, right? The trachea. So at the pharynx, right, is where you have the passageway. All right, the 16, next one. Let's see, let's do Lindsay.
Which of the following is not a function of the nasal mucosa? It will be C, dehumidify the incoming air.
That is correct, right? So about these questions, what you got to be very cognizant about is not, right? So it's a good thing you don't miss it. Sometimes they're tricky. They'll write not in not bold lettering, and you have to pick this up because everything else is in fact function, right? It humidifies the incoming, it dehumidifies the outgoing, right? traps a particulate matter, cools outgoing air. And the only thing that it does not do, right, it's dehumidify the incoming air, because we want to humidify it, right? We want to humidify it. So dehumidify incoming is not the correct choice. Good. 35. Let's do Christopher.
The elastic cartilage that covers the opening to the larynx during swallowing is the E, epiglottis.
Epiglottis is correct. This is also your landmark as you are proceeding with your intubation. So the way the intubation is going to work, once you have your blade in hand, you're going to do essentially, they call it epiglottiscopy. So you're searching for that epiglottis. You're looking for that sliver of the epiglottis. Once you find the epiglottis, then you're going to do valleculoscopy. You basically insert it into the vallecula and you're going to lift. So epiglottis becomes your very important landmark to locate. So good. Epiglottis is correct. 36. Let's do Milan.
The largest shield-shaped cartilage of the larynx is the thyroid cartilage.
Good. Thyroid cartilage is correct. It's this portion here. You're going to be feeling it, right? When we learn the procedure of needle cricothyroidomy, you're going to be looking for your cricothyroid membrane. But first, you got to find the thyroid. Then you're going to find the cricoid. And this is how you're going to be doing it. All right. Next question is 38. Let's do Brenda.
The ring-shaped cartilage just inferior to the thyroid cartilage is the D, cricoid cartilage.
Excellent, right? So as I was just saying, right, you're going to find your thyroid, then you're going to find your cricoid, and between is a cricothyroid membrane, right? Excellent. So it's good. 43, let's do Ian.
The laryngeal cartilage composed of elastic cartilage that prevents entry of solids or liquids into the pharynx when swallowing is D, epiglottis.
Good. So epiglottis is what prevents it. All right. So next question. Let's see. Let's do Luisa Castillo.
Question 49.
Yes.
The airway that connects the larynx to the bronchi, it's the A, the trach.
Trachea is correct, right? So yeah, the airway that connects the larynx to the bronchi is the trachea. The trachea is, the very important structure. You guys are gonna be practicing, right, with ventilation, intubation. So good. 54. Let's do Adam. Adam for number 54.
All right, 54. You can hear me?
Yes, I can.
All right. During a choking episode, most foreign objects are more likely to become lodged in the right primary bronchus due to its larger diameter and steeper angle.
So right primary is correct. Yes. Right. We talked about that in the lectures, right? It's bigger diameter. It's more vertical. So right, it usually lodges in the right. If for some reason it's in the trachea, right? That's when you're going to use your endotracheal tube to push that object further down. Hopefully, it will get lodged in the right side, and then you're going to pull your tube back into the original position, and you hopefully able to ventilate your patient. We're going to practice this procedure. Do not put your medial forceps if you do not see the object. So if you having hard time ventilating, hard time squeezing the bag, and you position the patient right, your head is in the proper alignment, all that is there, and you have hard time squeezing, there may be a foreign body obstruction. Just to tell you something to keep you aware, you may have patients who are on a ventilator for long periods of time, right? Especially now with COVID times. They may have mucus plugging, right? That happens in the ET tube. And if they have fever, they may not have enough essentially fluids in their body to have liquid mucus mucus secretions. Their mucus becomes very hard, and this may cause plugging in the ET tube. So if you're coming in with the ET tube and you're having hard time squeezing the bag, what I'm saying is your compliance is very hard. You may need to use sterile suction to put through the endotracheal tube. If that fails, like you still cannot get it to go, you basically extubate them and ventilate them with the BVM. Just something to keep in mind. I was sitting on the M&M conference, is basically morbidity and mortality, and the patient died in the hospital. They called the rapid response team, and they couldn't figure out the patient had mucus plugging in the ET tube, and they were doing all other stuff, and the patient died. But just keep that in mind, right? So if you're having hard time squeezing the bag, it may be a foreign body way obstruction if there's no ET tube. But if there's the ET tube and you have hard time squeezing, right, and if your tube is having that, try to suction it first. If still resistance, you may need to extubate them. All right, so 55. Let's do Kayla.
Which of the following statements about bronchioles is true? Is it E, segmental bronchi are branches of terminal bronchioles?
So the segmental bronchi are not branches of terminal. So the terminal is more towards, where you go towards the alveoli. But here, remember, I talked specifically about beta 2 stimulation in the lectures. So what do you remember, Kayla? What does beta 2 stimulation do?
That's for the lungs, right?
For the lungs, right? We talked about beta 2. So the way I remember, right? Remember I said in the lecture,
bronchodilation.
Yeah, you have lungs.
One heart, two lungs, right?
Correct. So heart, right? Heart is beta 1. So this is heart. Lung is 2 lungs. It's beta 2. So beta 2 causes bronchodilation, and it does so by sympathetic, right, action. The sympathetic action causes bronchodilation. You guys gonna be masters of this, right? Especially when you give your albuterol, when you give your epi injection. Epi is sympathomimetic. Albuterol is as well. It acts on beta 2. It causes smooth muscle relaxation. You're gonna have bronchodilation because of that, right? So which of these is true is choice A. All right. Number 57. Let's do Sarah. Sarah N.
The blank extends from the larynx to the mediastinum, and I put E, trachea.
Trachea is correct, right? So trachea is correct. By the way, what is mediastinum? Mediastinum. So let me see if I can draw this. I'm gonna probably butcher it, but so you have your lungs here, right? But in the center here, you have your heart, you have your vena cava, you have your artery, right? And all the great vessels. So what the mediastinum is basically all the stuff that's in the center between the two lungs. So the heart, the great vessels, vena cava, aorta, the esophagus that runs posterior, right? So what the mediastinum is all the stuff in the center of it. Sometimes you may hear this term. They will say in the ER, if you're doing your rotation, they'll say after they did the X-ray, after they did the chest X-ray, they'll say they have widened mediastinum. So widened mediastinum means they see that's here it's widening, right? Or something's going on, and that's usually one of the signs of aortic dissection, right? So in the aortic dissection, you have widening of the aorta because of the false lumen. So when they do the chest X-ray, they may see a widened mediastinum. So mediastinum means all the tissues in the center between the lungs. All right, 59. Let's do.
So Nick.
Yeah.
Nick.
Yeah.
Really quickly on that. So widened mediastinum meaning something, one of the great vessels or something else is making it wider. It's not like just empty space because something is shrinking or like that.
Yeah. So on the X-ray, that when they will do it, they will measure. You could measure the centimeters, and they will see the extended. Basically, the mediastinum here, it will be widened. Why it's widened? Sometimes, like in patients who may have aortic dissection, they may have a false lumen. So basically, what happens is, let's say if this was your if this was your normal aorta, they have a dissection in the lumen, and this created a false lumen. So now there's excess blood going here. So now let's say tunica intima, or tunica media, the layering of the aorta is dissected, and extra blood is pulling from the heart, basically squeezing there. So this vessel, the aorta, will enlarge. It will become bigger. So on the X-ray, they will see widened mediastinum. That's what they will call it, widened mediastinum. And usually that's one of the hallmark signs of aortic dissection, proximal aortic dissection. Yeah. All right. 59. Let's do, what else? Jessica.
59. The right lung has blank and the left lung has blank. I put A. The right lung has 3 lobes and the left has 2 lobes.
That is correct. The right lung has 3 lobes and the left lung has 2 lobes. I showed you plenty of pictures of that. I think that's an easy question. But okay. So let's do number 64. Let's do Curtis Heller.
The sites of gas exchange within the lungs are the D alveoli.
The D is correct, right? I think this is also an easy question. The sites of gas exchange is the alveoli itself. So yeah, that's the correct answer. We're gonna learn something about alveoli, I think, in the next question. Remember, just to give you a little thing here, alveoli, we wanted to keep them stented open. We don't want them to be collapsed, right? When they collapse, it's called atelectasis. So we want them to be stented open. There is a special thing that the lungs secrete called surfactant that stents them open. But I think there's some questions to that, so I don't want to give it away just yet. All right, 66. Let's do.
I'll do it if you want.
All right, go ahead, Angel.
All right, damage to the type 2 pneumocytes of the lungs will result in all of the, in all of the following except A, the loss of surfactant.
Yeah, okay. So I was getting to it. So damage to type 2 pneumocytes, right? Type 2 pneumocytes are actually cells that make surfactant, right?
Right.
Remember I said they found actually of the research that they did on patients who get COVID, right? COVID-19, is that as the disease process progresses and they get to like stage 3, what they found is the type 2 pneumocytes are affected by the virus itself. Surfactant is not being produced, and so you have that collapse. You have atelectasis. Like we want the alveoli to be like this, but in them they collapse, right? And then in here you have good O2, right, and CO2 exchange, but here you have very poor exchange. So type 2 pneumocytes actually make surfactant. So for 66, the actual answer is E, right? So remember in these questions, when they give you like accept or not, be on the lookout. Those are like the specific markers on the question. So accept or not, right? Or which of these is not, which accept this. So always be on the lookout. So the type 2 pneumocytes, right? What they do not do accept, right? The decreased number of dot cells. So that's the exception for 66.
Hey Nick.
Yeah.
Is a dust cell a real thing? I don't recall.
Yeah, I don't think it's a real cell. I don't think it's a real thing.
Okay, just
yeah. So, and the other thing is, if I look at the other choices, right, they all kind of make sense. The type 2 pneumocytes make surfactant, right? They decrease the rate of gas exchange, increase surface tension of the alveoli, increase tendency of the alveoli collapse. So, so damage to the type 2 pneumocytes if they make surfactant, right? If I make surfactant, I have damage to the type 2 pneumocytes, which is one of the pathophysiologies of COVID-19, right? Yeah, I will have loss of surfactant, I have decreased gas exchange, I have increased surface tension, and I have increased tendency for alveoli collapse, which is called atelectasis. That's why those patients place them on the ventilators, but they don't do so well, right? Because the type 2 pneumocytes are not really producing the surfactant. All right. 72. Let's see who hasn't gone. Let's do Brian. Brian.
The condition of having low tissue oxygen levels is known as anoxia.
So anoxia means no oxygen, right? So a low means there is some, right? So be careful of the words that they use. So when they're talking about low, right, it's usually hypo, right? No, you know how we say hypotension? Hypotension, it means low blood pressure, right? And hypoxia means low oxygen saturation and low oxygen there. So hypercapnia means elevated CO2. Hypoventilation means they're not breathing, which will essentially also give you high CO2. So the condition having low tissue oxygen is hypoxia. Anoxia means none. All right. Let's do 73. Who else we got? Let's do Crystal.
Pulmonary ventilation refers to A.
So a movement of air in and out of the lungs is correct, right? Ventilation, yes, that is correct. I think that's a fairly straightforward question. 79. Let's do Priscilla.
Air moves out of the lungs when the pressure inside the lungs is B greater than the pressure in the atmosphere.
Correct, right? Always moves from high to low pressure. So air moves out of the lungs when the pressure inside the lungs is greater than the pressure outside. So always from high to low. That's good. Number 85. Let me make this a bit smaller. 85. Let's do. Who else hasn't gone? Let's do Sakfir.
All right. Which muscles contracts to cause the movement indicated by the arrows labeled 6 and 7?
Yeah, so 6 and 7 being this.
Right. D, the diaphragm?
So are you saying E?
I'm saying D.
D.
Diaphragm.
Oh, diaphragm. So which muscles
I'm saying
contract, right? So truly speaking, right? For 6 and 7, this for a healthy person, this is essentially none, right? It's quiet and it's the expiration is passive. However, on patients who have COPD, this becomes active and they will be laboring to get that air out, because that's why they have barrel chest. They retain that air, right? So for them, it's no longer passive. But for healthy individuals, right, 6 and 7 means you're exhaling, and E is it's quiet, expiration is passive. Okay. Let's do 91. See who hasn't gone yet. I think everybody's gone. I think everybody's has gone.
I can go for it.
Go ahead.
That was 91, right?
Yes, 91.
Blank is the amount of air that moves into the respiratory system during a single respiratory cycle under resting condition. I believe that's D, tidal volume.
D is correct, tidal volume, right? So when you, on an adult person, it's about 500 ml, right, or 0.5 liters. So when you are, quietly breathing in a single respiratory cycle, yeah, that's how much air you're moving. Also be cognizant, right, when you have your BVM, right? This is 1.5 liters. 1.5 liters. So do not empty this thing for the patient. So if 500 ml is a roughly tidal volume, you only need just a little squeeze. Actually, you'd probably be better off using a pediatric BVM with adult size face mask, because then there's less tendency of emptying that stuff. But all right, so tidal volume is the correct answer. Next one is going to be 97. Let's do, we're going to start.
Okay.
Yeah, go ahead.
So alveolar ventilation, VA, refers to the, I believe, A, movement of air in and out of the lungs.
So alveolar alveolar ventilation is basically a slightly different, right? So here, when we're talking about alveolar, they're specifically talking about when it gets to the alveolar tissue. But remember, so if this was your alveolar tissue, and this is where you have your gas exchange, right? All this stuff here up until this point, right? This is dead space. So if you recall from the lectures that I did, I basically say the actual alveolar gas exchange occurs at this portion here. All the oxygen that you breathe in that's still in your proximal airways that didn't get to the actual point of exchange is not being utilized, right? So this is dead space. So the alveolar ventilation will be actually reaching the amount of air in the alveoli, right? So for this, the correct answer is B. Remember when I did the calculation, we did 500 minus 150 for the dead space? And we said, then your tidal volume becomes 350 ml. So if you rewatch that portion of the video, you will see that. All right, 98.
Isn't that alveolar minute volume?
Yeah. So it's alveolar minute volume when you calculate it, let's say times 12, right? But alveolar ventilation in itself, right? The ventilation is occurring at the alveoli. That's why they put it specifically alveolar ventilation, right? So alveolar ventilation, they're specifically targeting this portion here. So for 97, the answer would be B. All right, 98. Helmi, you want to do 98?
No problem. Blank equal the respiratory rate, tidal volume, automatic disk space equal the respiratory rate, tidal volume, and automatic
You just said it early. That's why I picked you.
It's respiratory minute volume.
Is which
vital
one?
capacity.
So basically what this saying is, remember how I just wrote, right? So your tidal volume is 500, your anatomic dead space is 150, right? Times the respiratory rate times 12. So this becomes 12 times 350. So this is where is this occurring? Where is this occurring? At what portion of your, right? So
in the alveoli, in the vital capacity.
Alveoli, right? So which one of these choices has alveoli?
Ventilation rate.
Right.
D.
Excellent, right? So when we talk about when we subtract the dead space, so this 150 is the dead space. Dead space, just to sum up, dead space is the amount of air that's in your proximal airways that's not participating in gas exchange. So what's that space? That space, so like I take a breath in. There's some air between my mouth and before the alveoli that's not really participating in gas exchange, but it's still in my lungs, right? I inhaled it. So this is the dead space air. So that space is the amount of air that you inhale that's not actively participating in active gas exchange. And when we want to calculate it, we call it alveolar ventilatory rate. And the way we do this is basically we take the tidal volume for the person, we subtract the amount of dead space, and we multiply it by how many respirations they take, right? 12 times 350, and that your alveolar ventilation rate. All right, let's do 99. I'm going to start calling on people who already went, who have their hand up. Let's do Ian again. Ian for 99.
Which of the following can be calculated if the tidal volume and respiratory rate are known? I put A, respiratory minute volume.
Yeah, this is your base. This is your calculation, right? Your without the dead space. This is your 500 times 12, right? So which of these can be calculated for? Tidal volume is known, 500. Respiratory rate is known as 12. Respiratory minute volume is what you get. So good, correct. 101. Let's do Kayla.
Air remaining in the conducting portion of the respiratory system that does not reach the alveoli is known as dead space.
Dead space is correct, right? I just, basically explained this. So yeah, correct. Any air that does not participate in active gas exchange is dead space. So dead space is anatomic dead space here being the correct answer. Good. All right. We got number 104. Let's do Lindsay.
The partial pressure of oxygen, PO2, in pulmonary veins during internal respiration is E 95 millimeters mercury.
Yeah, 95 is correct. Sometimes some books will say 100 millimeters mercury. Also correct. The basically pulmonary veins, right, is the portion of the circulation that has oxygenated blood, right? And we know that the pulmonary artery, right, pulmonary artery is what takes the deoxygenated blood from your body, goes into the right side of the heart, the right atria, the right ventricle, then pulmonary artery, then it goes to the lungs, right? Then it goes to the lungs, and the lungs, oxygen gets loaded, goes into the pulmonary veins, and then you have the oxygenated blood. 95% is the correct choice. Yep. 109. Let's do Sarah Ann.
Most of the oxygen transported by the blood is, I put B, bound to hemoglobin.
That is correct, right? So hemoglobin is your major transport molecule. We basically went into great detail about that, right? O2 is bound to the iron, and this is what we got. That's excellent. All right, 111. Let's do.
Could I go?
Yeah, go ahead, Aaron.
Hemoglobin molecule contains blank globular protein subunit, 2 alpha and 2 beta.
Excellent, right? The 2 alpha, 2 beta. Usually here, right? We said it was a tetramer, just to give you guys an idea how it looks. Alpha 1, beta 1, alpha 2, beta 2, right? And you have 2 beta subunits, you have 2 alpha. The beta subunits are the one that usually bind the 2,3-DPG, right? In the fetal hemoglobin, just to give you an idea, alpha 1, alpha 2, gamma 1, gamma 2 does not bind 2,3-DPG, right? And that's one of the distinction to remember. But yeah, so 4 units, it's a tetramer. It has cooperativity, means as one oxygen binds, the second one is easier, the third one is more easier, and the fourth one is the easiest. So that's good. We'll do numbers 116. Let's do Brenda.
Which of the following factors would increase the amount of oxygen discharged by hemoglobin into peripheral tissues?
So the question is asking you which one of these is gonna right shift? Which one is gonna make it more tense?
C, increase tissue PO2.
So oxygen will not right shift, right? Remember we said, remember we talked about the Bohr effect?
Oh, that would, right.
Bohr effect. So what factors right shift? So let me just, this is your normal, and when I say right shift, this would be the right shift. So we move it this way. When we right shift, it means offloads O2 better, and it also takes up the T state. So usually that is done by decreased pH, right? It will decreased pH means acidotic, or they have high hydrogen ions. or this can cause by increase of CO2. So all these factors will right shift. So decrease in pH will increase the amount of oxygen that's discharged. So basically, the hemoglobin becomes a better deliverer of oxygen to the tissues. How would you remember this? Think of a patient, right, who has sepsis, right? Think of a patient who has diabetic ketoacidosis. They may have decreased pH. They have acidosis in the body, metabolic acidosis, and the tissues needing more oxygen. They want to extract more oxygen. So this at the tissue level, right? These things will bind on non-iron sites, and this will right shift your oxyhemoglobin curve, hopefully to better deliver the oxygen. Okay, 117. Let's do Ajaya. If I'm mispronouncing it, just say it right.
AJ is fine. Thank you. That's fine.
AJ. Okay. 117.
For maximum loading of hemoglobin with oxygen at the lungs. Sorry, hold on. I'm having trouble. Hard time seeing there. Thank you. I'm gonna go with E. PCO2 should be low.
Yeah. So that is correct. So that is correct,
Oh,
right?
okay.
So this is actually this is this is the opposite of the Bohr effect. This is the Haldane effect. I don't want it to bring it up because there's just too much stuff for you to remember. But but the way it works is right in the lungs. For hemoglobin to load with oxygen, we got to get rid of that CO2. If I get rid of that CO2, I switch from the tense state to the relaxed state, right? As more O2 is coming in, right? So the PCO2 should be low. It should get rid, in the lungs. CO2 comes out, oxygen loads, becomes from tense to relaxed state. So, and this is the Haldane effect. But
I'm sorry. Can you write that like on the thing so I can see how it's spelled? You said the Haldane effect. Thank you.
Yeah, I wouldn't worry about that. You don't. It's not that you have to know this or the Bohr. It's just I guess if you are a scientist or you're a doctor, you find this and you put your name on it, and then everybody has to call it that. but for your purposes, if you know the AMP of it, that's fine. All right. So 118.
Okay, thank you.
Yeah, no problem.
Nikolai, quick question.
Yeah.
So going back, for CO2, it's the opposite, right? So CO2, it's higher at the capillaries, and then it wants to go from a higher pressure to a lower pressure.
Yeah. So let me go back to the other stuff so you guys see. There you go. So look, this is your alveolar tissue, right? Right here. In your alveoli, you're connected directly, right, as you're breathing into the atmosphere. And we see that the oxygen that's coming in, we have 100%, right? Or you may even say 95, but it's fine. Keep it 100. That's okay. 100 oxygen, right? The partial pressure of oxygen, and the CO2 is 40 at the alveolar level. So as the red blood cell, you see how the red blood cell comes into the contact with the alveolar tissue. So this is the alveoli, and this is where the circulation, right? The pulmonary capillaries are. In the pulmonary capillaries, you have the simple squamous epithelium, right? So you have good gas exchange. The red blood cell comes in, and what happens is from high to low pressure, right? So from high pressure, oxygen is going to get loaded, and CO2 is going to get offloaded. Why is CO2 gets offloaded? Because this CO2 was picked up from the tissues. It was 45. So 45 is here. So the CO2 was 45. So from high to low pressure, it's going to come out. Oxygen from here is going to load in. When the red blood cell gets to the tissues, right, in the now systemic capillaries, right, systemic capillaries at the tissue level, this now has 100% oxygen and it has 40 of carbon dioxide. So oxygen would want to go into the tissues because oxygen is low, because tissues use oxygen for their metabolic needs to do oxidative phosphorylation, right, to make ATP. And oxygen gets loaded. And then here we said the CO2 was 40, and it goes from high to low pressure to here. So then this molecule becomes, right, 40 in oxygen and 45 in CO2 when it gets back to the lungs. Does that answer your question?
Yeah, thank you.
Yeah, so it's always the flow is always from high pressure to low pressure in terms of this, always from high to low pressure, always. Right? So we'll resume back to our 16. So we were 118 and 118. Let's do Kayla.
119.
118. We answered 117. Yeah, 118. This one here.
Most of the carbon dioxide in the blood is transported as bicarbonate ions.
Yeah. So it's transported as bicarbonate ions, bicarbonate being HCO3 negative, right? I showed you the picture, right? Let me just go back. I think it's a good thing to show so you guys can see it here, right? So you see this is your arterial and venous blood, and we see that the bicarbonate HCO3 minus this here is the predominant, right? The remainder is carboamino, right? What is carboamino is basically carbon dioxide, CO2 bound to hemoglobin, and some carbon dioxide is dissolved in the plasma, but it's very minimal amount, right? As you could see. But for your purposes, if you remember, the bulk of it is in the bicarbonate form. CO2 is in the bicarbonate form. How does it do that? It basically, through this equation, the carbon dioxide, right, combines with water, and then carbonic acid dissociates into bicarbonate, and that's the bulk form that's found in your body. This formula will be crucial for you to know, both for your respiratory lectures and components, also when we do renal, because renal is also using the same stuff, right? So good.
Hey, Nick.
Yeah.
So here's a question.
Mm-hmm.
What happens when we drink club soda, for example? When
Club soda?
All the CO2, I mean, isn't that carbonic acid right there?
Yeah, it just fizzles out as you open this up. It just fizzles out. The carbon dioxide that I'm referring to here is the carbon dioxide metabolically produced by your tissues, right? So like if I'm doing aerobic respirations, right? As you break down your glucose, right? So you take glucose, and glucose gets broken down with glycolysis steps. Then it goes into Krebs cycle, then goes into electrotransport chain. But the glucose in itself, right? Glucose has carbons in it in the skeleton, right? And it has oxygen. So as it's get broken down in your glycolysis, the CO2 basically gets puffed out here, and the tissues that utilize glucose for their metabolic needs, they produce CO2, and it gets puffed out into your respiratory system. So the CO2 from your club soda, I wouldn't worry about.
Thank you.
Yeah. 121. Let's do Brian.
What does not happen to a carbon dioxide molecule once it enters the bloodstream? E. It binds to the heme group in hemoglobin.
Excellent, right? I was like kind of hoping you guys get this one right? So what does not happen to carbon dioxide? We said it's either gets not broken down. It combines with water and makes bicarbonate, which is the predominant thing found in the plasma, or it can bind to carboamino unit, right? It's basically the globin chain of the hemoglobin, but not, right? It doesn't bind to iron, right? It does not. So it does not bind to iron. So they basically said what does not happen to carbon dioxide, it doesn't bind to the heme groups on the hemoglobin. This, right, the iron only binds oxygen preferentially, and in cases of carbon monoxide poisoning, it's going to bind carbon monoxide. Good. All right. 139. Let's do Priscilla.
The most important chemical regulator of respiration is, I believe it's B, carbon dioxide.
So yes, carbon dioxide is correct. You know, to be truly speaking, right, they don't have it here. But if you want to be like precise, right, it's actually hydrogen ion, and it's because of the pH gradient. Why? I'll tell you why. Because we said CO2 molecule, right, is this molecule here, and it will not cross the blood-brain barrier as easily. But the reason why they say it's CO2 because they know that CO2 with water, right, is going to be carbonic acid, and then carbonic acid is going to be hydrogen and bicarb. And this here, and truly speaking, H, right, concentration is the pH of your body, right, of your plasma. And what the brain sees, right, the receptors on the brain, the chemotoxic area, they see that's hydrogen ion. So truly speaking, if you want to be precise, it's the hydrogen ion, and this is the molecule that's small enough to cross the blood-brain barrier, right? But the reason why they have carbon dioxide is because they know that this, basically will go this way and make hydrogen atoms. But just keep in mind, right? It's this. Oftentimes, I hear people say CO2 is an acid, and that's what's responsible for that. CO2 is not an acid, right? But what truly does happen, CO2 comes with water, and it forms with this reaction to the hydrogen ion, and this is what truly determines, the regulator of your respiration. Because if pH drops, right, your pH is going down. I want to increase my respirations, right? If my pH is going up, alkalosis, maybe I want to decrease my respiration. So that's basically what this is. The next one, let's do. I haven't gotten. Let's do Ian again.
Where am I?
We're at 141. Let me just erase all this. Yeah, 141.
Okay, so the term hypercapnia refers to B, elevated PCO2.
Yeah, that is correct, right? Hypercapnia is elevated PCO2. So you will hear this term often, right? Hypocapnia means low PCO2. Hypercapnia means high. Those terms should be kind of familiar if you remember. Hypotension, hypertension, hypoventilation, hyperventilation. By the way, just since we are on the terms, hypercapnia means elevated PCO2. So would the person be hyperventilating or hypoventilating when they have hypercapnia?
Hypoventilating.
Say it again.
Hypoventilating.
Hypo, yeah. So hypo. So hypoventilation means my ventilations are lower, which will retain my CO2. So I will become hypercapnic. If I have hypocapnia, so right, then I am hyperventilating. So they're in opposites. As long as you remember that. I don't know if you'll have any questions on that, but I think that's it. Yeah, this is it. Any questions about the respiratory stuff? Anything we did about hemoglobin saturation, desaturation curves, about intubation, anything like that. This I would say for you, this stuff will be extremely important, especially for intubation procedures, especially when you are pre-oxygenating. Please do not use the term I wanna hyperventilate my patient. When we're going to be practicing this in the skill, make sure you utilize your pulse ox. Make sure you put it in a space, in a place where you could actually see it. Right, you see the number, so you're looking at it. And if the instructor tells you, okay, your saturation is going down, it's now 90%, you should stop your procedure. You should go back to pre-oxygenating, and then seeing that your pulse ox is rising. If you do that, even though you were not successful in your first attempt, but you pre-oxygenate and you get successful intubation in your second attempt, that will be a successful pass. But if you keep pursuing your attempt without, looking at the pulse ox and not taking corrective action, that will be a critical failure because that can cause essentially death to the patient if you don't correct it. So that's very important. If there's any questions, you can ask them. Certainly watch those lectures and for the respiratory component. I also have videos, in terms of intubation, how to place the patient properly, and I have a video laryngoscope. Basically, it's a device that shows you all the structures, how it goes through, the finding the epiglottis, finding the valleculus, and doing all that.
Where did you say the skill sheets were, so we could download
Yeah,
them and
skill
print them?
sheets. Yes, the skill sheets. If you go on Google Groups and you find the emails that were titled medication math that was sent out, I believe Matt may have forwarded after I sent it to him. So look for med math videos. Those medication for IV bolus and piggyback, both of those videos have a link to all the skill sheets. So it's a one document. You could download it. You could put it on your tablet phone. It has all the skill sheets. They will be exact same ones that are found in your FISDEP, but they will be in PDF format. So and the way I would do it, if I was, if I was in your shoes, I would look on the schedule or, find out what's the next skill we're doing. Okay, we're scheduled to do, let's say, intubation. So I will download all those skill sheets. If we're
That's
doing
what I want to do.
yeah, piggybacks, you download those, take a look at that. I would also, it's not going to be on the skill sheet, but I specifically said to look up indications, contraindications. So I would, you don't need to become a PhD in this, but I would at least Google, and look up in your book if you can, why we're doing this procedure, because you definitely need to know why you're doing this procedure. And it's not because you can, it's because the patient meets the indications and there's no contraindications present.